Okay, so this first treatment technique is going to be for someone that comes in and they've got a pain and or restriction into flexion of the hip. So it's a hip treatment. So for Glenn, what would we do for that sort of restriction or pain?
A couple of things to consider first. I think you'd want to establish what is the driver behind the pain. Is it arthrogenic or myogenic or neurogenic? Using your assessment tools and your clinical reasoning to establish that. We're going to say in this instance that it's more of an arthrogenic component. So you might expect stiffness or pain in the hip passively and also actively as well. And your accessory glides might confirm that also, in special tests. So the next thing to consider is irritability. So how irritable or severe is the pain? So your sin factors that you'd always consider. So if someone comes in and they're very acute and the pain's very high and it takes a long time to settle, that's obviously going to be a different treatment technique that you would use initially than if they, it takes them half hour of running to bring the pain on and then it settles immediately when they stop. Let's assume we're starting with quite high irritability and severity then, and if we get you laying on your back, thank you very much, we'll do a real basic AP glide, on the hip joint, and we'll go through a few variations on that. So if we pop the towel under here, what I'm going to do, just come close to the joint line, hand will rest on the top of the femur, and I'm literally just going to do a very, very gentle AP glide. I'm making sure that my forearm is in line with the femur and the direction of the force that I'm applying is going down towards the couch. How does that feel, PJ? Okay?
Yeah, feels great.
So it's very rare that people will get their pain in that range. Normally it takes a bit more flexion. So the progression from that would be to take the leg up into the point where the pain would onset. So normally it's around 90 degrees at most commonly. Would you agree with that?
Yeah, definitely.
Same thing again, hand at the top of the femur. This time the direction of the force is down towards the feet, because we've changed the angle of the thigh, of the hip. And same thing here. As I'm pressing down through my left hand, my right hand is kind of counterbalancing that as well to create the fulcrum at the hip joint.
And would you do this one with movement as well?
Yeah, that would be the next kind of progression from there. So you can do it in neutral with a little bit of a towel at the point of pain, and then you can include the movement itself.
So actually glide as you're going up into flexion.
Exactly, yeah. So in that instance I might put the glide on here and then literally bring the joint up into flexion and then back down.
And when you're doing those glides, are you grading it in your head, or how are you kind of doing it with regards to that?
Yeah, we could talk about the grading system, the maintenance system, so you've got 1 or 2 not into resistance, more for pain relief, or into 3 and 4, different amplitudes of movement but into resistance. I think with a mobilisation with movement like that, I would go 3-4 into a bit of resistance, hold that on and then glide it. If Patrick was very, very irritable, it would be based on his response. So if I could do a smaller grade without causing pain, that's where I would start. If I could increase that grade a little bit and still not provoke his pain, I would do so.
And I think it's important to remember, we'll mention this in a few of the videos, but with the mobilisations, a lot of the evidence suggests that there's not that good reliability in terms of how much pressure you put through. So the interrelator reliability is not great, so different clinicians will, so Glenn and myself might actually be pushing and saying it's a grade 3, but it'd be at different pressures, and there's not much consistency with that, and also that even yourself, as you get more senior, you do become more standardised with the pressure, but it's still quite varied. So I think, like you said, really we're going more on the kind of symptom of the patient. So whether you can do it without pain if you're doing more of a more pain control, and you're looking for the responses with the other guys. So if it's for resistance, then you're looking again to improve the range, or to have less pain when you do that. And I think going on those things rather than kind of getting too bogged down with the grades is probably a good way to go.
Yeah, I'd agree. And ideally, if you can, it's better to go for a larger grade and a bigger amplitude to stimulate more mechanoreceptors and get that kind of pain inhibition effect as well, as long as the patient can tolerate it, obviously.
Yeah, definitely. Perfect.